most of you are very familiar with the basics in informed consent. It's in some ways, from a theoretical perspective anyway, not complicated. The ideas are that we allow people to make their own choices. It's voluntary most of the time, that we inform them about relevant or material information, and that they're competent. Those are the three big ones. It's kind of interesting to me that informed consent, while theoretically it's a no-brainer, how relatively infrequently people really engage in informed consent with clients. Large systems, for example, have these informed consent forms. Many of us have had the experience, and when you're going in for surgery, here, read this and sign it. There's still quite a bit of ambivalence about engaging people, engaging clients in an informed consent process, which in my mind, the issue that you're raising, is exactly what would need to happen when we talk about a different direction for treatment with a client than they want. And having some justification, but also actually having a fairly frank conversation. And I think part of this is, in some respects, a conflict between a value of autonomy and respect for personhood and a kind of parentification or a parens patriae approach. Who gets to decide? Right? The assumption is, under at least this theory, that because of our humanity, we get to be respected. If we're adults and we're competent, our decisions garner respect. And it's a respect for moral agency. And what I mean by that, in ethical theory, what moral agency is, that you're a person who is responsible for the consequences of your conduct, that we make choices. A lot of psychology suggests, a lot of research suggests, we don't make anywhere near the choices we think we do. But from ethical and legal theory, the notion is that we are moral agents, and that when we make decisions, when we choose one kind of treatment over another, when we say, I don't want to be in therapy, that is to be respected, no matter how foolish it may seem. Your foolish decision may be brilliant for you, that I think is foolish, and vice versa, because I'm not in your shoes. I'm not in your life. I don't have the constellation of factors that I'm dealing with. So this honoring of moral agency and allowing for, or a foundation for, responsibility, even if the person is someone who doesn't really want to be responsible, doesn't really want to take the consequences, it's allowing people and supporting people in making those decisions. This particular theory has been around in kind of Anglo-Saxon law for a long time. In the US, one of the first cases is the Schloendorf case. There's an interesting case because it was based on physical touch, on a battery theory. So when I touch you and you haven't given me consent, that's considered an offensive touching, and it's a battery. I could be prosecuted. You could also sue me for touching you when you didn't give me permission. And it was a case that involved a woman who was going to go into the hospital for exploratory surgery. Apparently, I don't know if it was an ulcer or something of that nature, but she was going into the hospital for exploratory surgery, and she explicitly told her surgeons, I don't want you to take anything out. I just want you to go in and tell me what it is, and then we'll decide. This was 1911. Survival rates from surgery were not high. Going into another surgery was a really risky proposition. Gangrene was a very significant risk for any kind of surgery. There were no antibiotics. Okay. This is what this particular woman wanted. Physicians opened her up, and they saw, I think it was a growth or something, and they decided, we're here, we're going to take this out, the risks are really high, and they sewed her up again. Well, she developed gangrene. Again, this is not an unusual outcome in those days for surgery. But she sued them. And the theory she sued them under was not that they had opened her up and something bad had happened, but that they had removed a part of her anatomy without her permission. They had engaged in a battery. And in a this is a case that's well known in informed consent circles and people who do medical malpractice, because it was then Judge Cardozo said, every person has a right to decide what happens to their body. And it was one of those cases where there was a fundamental distinction made that you and I get to decide. If I'm non-compos mentis, and I say I give you, the authority to make decisions, then you may decide on my behalf, but I've given you that power. I've given you that moral agency, if you will. The cases kind of moved along in that physical touch line until the 70s when we had a case called Cobb versus Grant, California case, not a New York case. So it actually has precedence here. And it involved a man who had just a series of horrific experiences getting surgery. You know, some of you, if you have kids, you've seen that book, No Good, Awful, Terrible Day? He had a no good, awful, terrible year. And he's somebody who experienced all of the negative repercussions of surgeries one after the other. And they were all known risks, so it wasn't malpractice. He went in for an ulcer. They gave him palliative treatment to begin with. They said, you're going to have to get surgery. As a result of the surgery, one of the known risks was injuring the pancreas. He had to go in again within a month and have his pancreas removed because he experienced tremendous pain. He went back home. He was okay for a few days, then began to experience another really intense abdominal painful experience. And it turned out that he had developed yet a different kind of an ulcer that was one of the risks of the surgery. So he had to go in and get another kind of surgery. And then I believe within another few months, yet a fourth kind of surgery. All of them were known risks. He sued his physician in malpractice and in a failure to give informed consent. The malpractice part of the action was basically done away with. It was dismissed. The judges in the courts decided there was no malpractice as a matter of law because all of the things that happened to this poor man were things that were predicted side effects. They were not by virtue of mistakes that were made. But, the court said, it had to go back down to the trial court to determine whether he'd been told about all these risks. So this was a case that spoke to no malpractice in its old sense, but was there a failure to get informed consent? And here it wasn't of touching that was offensive. It was not letting him know about the potential risks in sufficient detail so that a reasonable person, a reasonable patient in his shoes could make a decision about which direction to take. That was a really critical case for our purposes because when it removed informed consent from a battery theory, from a touch that's offensive theory, it now made it possible for it to become part of any kind of interaction, healthcare or human service. That if there are risks or benefits, that we're supposed to talk about it. So what was developed and what I've already mentioned is this idea the person is free to agree or refuse, that they're competent to assent, they're not compromised cognitively, they're not a child, and that they have the necessary information. They have what the courts call in California material information. And material information is what you would need to know if you were a reasonable person, theoretical reasonable person, to decide whether to go, for example, with a particular surgery or refrain from that surgery. To undergo psychotropic medication for a very serious OCD disorder, or to refrain from engaging in that psychotropic medication. To undergo any kind of therapeutic treatment, the idea would be that you'd need to know what the potential benefits were, and very importantly, the potential risks, the material risks. So that was seen as kind of the crux, getting enough information so that a reasonable person, theoretical reasonable person, not this particular client, but in general, this is one of the standards, there are other standards that I'll mention, would be able to make a decision that would make sense to them, not necessarily to the psychologist or physician or other person who is providing the service. Well, the notion of what's material has morphed somewhat over the years, and it includes things like the nature of the services, what the person is going to undergo. So explaining, if I'm going to do a custody evaluation, I'm going to be meeting with you and your partner separately, and then each of you with your children. I'm going to be interviewing you. I'm going to be interviewing doing collateral contacts with schools and with other relatives, and I'm going to do a structured observation of you and your child, letting people know what the nature of the services are that are going to be undergone. At least some detail. We don't have to say, well, okay, this first session, Although in some situations like custody evaluations, you end up doing that. You just kind of lay out what it is that you're going to be doing. But for most treatment, we're going to give people information in a general way about what they can anticipate. We're going to talk about some of the potential risks and limitations. Medications are one of those or potential risk to medications, for example, we could talk about. They're not the only treatment, and they may have potentially negative side effects. Same with psychotherapy. About 70 or 80% of the time, people improve with psychotherapy. Folks who seek treatment do show improvement. They don't all overcome whatever it is that they have come to get help for, but 70, 80% of the time, the literature suggests, if we can believe it, that there is improvement. That's pretty darn good, even for medical intervention. And problem is that some people get worse in therapy. And people, for example, with borderline personality disorder on the more severe end of the spectrum, or DID, without a lot of support and a lot of skill building, will sometimes really disintegrate. So some people get worse, and there are people who don't get better with lots of therapy. The literature and cases typically don't talk about our describing potential benefits, but it makes no sense to talk about what the risks are if you also talk about how it's going to help. It just doesn't make any sense. General ideas of purposes and goals, and then alternatives. And I actually want to talk a little bit about alternatives in particular. It's not easy sometimes to develop or to think about what are the alternatives to doing, for example, as we were just chatting about, CBT for an isolated phobia or dynamically oriented treatment. What's an alternative to that? Well, medications are an alternative, but it's not like we have this broad range. Oftentimes, although there are different slight variations in approach, the basic idea is we could do one-to-one or group therapy. We could do medications. So the idea here is to be talking about what, even if they're limited, what the alternatives might be, even if that alternative includes no treatment at all. And talking about the no treatment alternative is an important thing to be able to do. And one of the things that, this is kind of an old case. Some of you may have heard of the Osheroff versus Chestnut Lodge case, the early 80s, 1980s case, that involved a nephrologist, a surgeon, who was experiencing a very intense depression. And he'd been in a psychoanalytic, come on in, please, psychoanalytic psychotherapy. And interestingly enough, I didn't find this out till years later, he was on psychotropic meds during some of that therapy, but he decompensated. So he was hospitalized at a place called Chestnut Lodge, which was one of a fairly few at that point, and now almost virtually non-existent places where one could do inpatient psychoanalysis. He was there for about 7 months, and unfortunately he continued to decompensate. He was, his depression and kind of obsessive nature of his depression got so bad that he had to get medical attention for his feet for cutting, swelling, because he was pacing so much. With a fair amount of back and forth, his family got him transferred to a different hospital where the focus was on medication. And within a couple, 3 months, he was doing well enough to go back into his life and practice and so forth. And he sued his psychiatrist, and he said that the psychiatrist had, among other things, a duty to have told him about medications. Now, this is an odd case because we had a physician. I'm sorry, you can't tell me that a nephrologist didn't know in 1982 or 84 that there are such things as antidepressants. I mean, it's kind of a far-fetched notion. But one of the places that I think there's some accuracy is that when we become clients, we are in a more vulnerable position. And so the idea is that there's some duty to give the information, even if you think the person may already know. Right? So I think that was part of Dr. Osheroff's argument. And the case never went to trial, was never appealed. So it is not precedent. It doesn't stand as a legal precedent in Maryland, which is, I believe, where it initially took place. It was either Maryland or the D.C. area.
It's Maryland.
Maryland? Okay, that's Chestnut Lodge, right? Pat, it's no longer in existence, is it? Or
Yeah. I worked in Maryland, and we would take patients from Chestnut Lodge. So this is back in 1985 or so. So as of 85, they were still, but they were not at all psychoanalytic.
Really?
Completely converted.
Wow. So
I
this,
think this case had
yeah,
huge.
this had a huge impact. This particular case underscored our possible liability for failure to obtain informed consent. That was the argument that Dr. Ashraf was making. And it was a case that was much debated. There was quite a bit of controversy that emerged. He apparently came to a meeting of the American Psychiatric Association and spoke to psychiatrists about this case, and that what his belief was about the need to use medications and use basically what he was arguing was the standard of care. And this case presaged the evidence-based practice movement, because it was about, do we have a duty to use services that are evidence-based, but also to tell our clients about those services that are available. But it raises in my mind this notion of what happens if you don't do treatment, or we offer you various alternatives. What if we give alternatives and clients are not interested in any of them? You raised this a little bit earlier with the client. You're saying, well, the way I work is to do X, and the client says, I don't want to do that. That's been couched in terms of non-compliance, and I actually have a slight difference here from the literature. I actually think that language is problematic, because if we're really honoring people's autonomy, it's actually a choice not to do what it is that we're asking them to do. It's not like the person has to be compliant, and we're building a relationship. So it's not simply about one way or unidirectional. That being said, if we fail, or the person fails to get treatment, even if we give them alternatives, are we fulfilling our informed consent obligation? Well, there's a case that was actually a California case, but before the Ashraf case. So it was about 5 years before, 4 years before the Ashraf case, that actually was and is good law in California, that involved a woman during the 1960s who was seeing Dr. Thomas, and he was her GP. And at least based on the appellate record, over the course of years, he said that he continued to remind her that she needed to get a pap smear. And she continued to find reasons for not getting a pap smear. Couldn't afford it, didn't have time, we'll get it next time. And over, it may have been 7 or 8 years, never got one. And then was relatively rapidly diagnosed with an advanced cervical cancer and died from that cancer. And the family sued Dr. Thomas and said that they failed to tell her what the consequences of not getting a pap smear were. Okay? Now remember, this was the 1960s, so it's not a bad argument at that time. It's not like everybody knew this. This was just kind of a practice that was relatively new. It wasn't brand new, but relatively new. But it raises the issue of how much is too much? When should we be saying to folks, look, if you don't do this, all kinds of bad things will happen, like our hypothetical dissociative identity disorder client.